Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and Med Talks, I welcome you all yet another episode of 52 Weeks of Diabetes Essential with Dr. Sanjay Kalra. Doctors, that as new advancement in diabetes care is happening day and night, as so that today's topic is on the same that technology and diabetes. And today's social session is brought to you by your zero calorie hydration partner Enerza Zero. Now, to enlighten us regarding today's topic, I would like to welcome our host, Dr. Sanjay Kalra, sir, President, South Asian Federation of Endocrine Society. Over to you, sir.
Thank you, Ankur, and good evening, everybody. I am reminded of this Hindi song, Sorry Tujhe, Sunday के दिन जहमत हुई, मिलना तेरा फजले खुदा रहमत हुई. Warm welcome to Mr. Sharma as well from Lucknow. And अब है तो ये उर्दू के अल्फाज, सॉरी तुझे संडे के दिन जहमत हुई, मिलना तेरा फजले खुदा रहमत हुई. But we can understand in English as well. Sorry we troubled you on a Sunday, but it is God's will that we were to meet. And I think it is God's will that we keep on meeting each other every Sunday evening, same time, same day,
Right,
and
sir.
we keep on learning more and more about diabetes. Thanks to Ankur and his team as well, led by Mr. Anand Basu, who very selflessly share this platform with us. And thanks to Pradeep and Regan, who work with us backstage to ensure that we are able to use the best technology in the world to share our information with each other. Now that we have spoken of technology, let's speak about technology in diabetes today. Ankur, I hope that my slides are visible.
Yes, sir.
Yeah. Now, traditionally, technology in diabetes has been divided into two groups. One is technology for taking insulin, and the other is technology for checking plasma glucose. Technology for taking insulin, we understand. We have syringes and vials. The quality of syringes has changed over the past 100 years. Instead of vials, we now have pens. The pens can be durable or disposable, permanent, reusable, or temporary. So, durable or disposable. In a durable pen, you have a cartridge which gets thrown away. In a disposable pen, you have just one cartridge which has to be thrown away along with the pen. In a durable pen, you keep on reusing the same pen and you keep on adding cartridges every time each finishes. Most pens have got cartridges which have 300 units per ml of insulin, but Glargine U300 comes in a 450 units per ml packaging. So that's technology for taking insulin. But we'll talk today about newer developments in insulin delivery. That is, apart from syringes and vials, apart from pens and cartridges. The second aspect of technology is technology for checking plasma glucose. So we know that we check glucose with glucometers, right? We can also check urine ketone. We can check urine sugar. Do note that when you're checking plasma glucose, it's called glucose, and when you're checking urine, it's called urine sugar. So, but then there are newer aspects of technology that are used now to check glucose. So we'll talk about that as well. This is traditional classification. But what is getting added now is technology to help you manage your diabetes, like apps for carb counting, ketone monitors, apps to sort of help you navigate your way through that complex maze of diabetes. So this is called digital therapeutics, and we'll talk about that as well towards the end. Now, technology for taking insulin, apart from the subcutaneous insulin that we use, we can also give insulin uh, through an infusion pump. So these insulin pumps are there. Traditionally, the pump will look like what you see in front of you. It will look like a small uh, pager. You keep it in your pocket. There is a tube which gets connected into a very tiny 4 needle, and that goes into the subcutaneous space. Pumps have evolved also over the past 50 years or so, and now our devices have become more user friendly. They've become much smaller. In general, A continuous subcutaneous insulin infusion pump will consist of a pump reservoir, which will contain one cartridge, a small battery operated pump, the battery lasts a long time, and a computer chip. You can program your insulin delivery, and once you do that, even with the earlier pumps, a lot of numeracy was required. Numeracy in terms of knowing how to program a basal dose and a bolus dose, how to do stepped up and stepped down basal doses, how to do carb counting. Now, all that is not required anymore because with the newer pumps, of course, they're expensive, they will cost around 5 lakhs. But with the newer pumps, all these calculations are taken care of by the pump itself. You put a starting dose, right? And then the pump itself is able to figure out whether you are going into hypo or hyperglycemia. The pump is also able to look at trends. Before you go into hypo or hyperglycemia, the pump will figure out, yes, the way things are moving, we are going to go into trouble. So let me change my dose. So it will change its basal dose. And this is the advantage of insulin pumps. It gives a lot of freedom to the patient. Of course, there is a cost involved to it, but the flexibility that the person living with diabetes gets, that is difficult to measure in terms of rupees or in terms of dollars. So this is something that is available. Whom would you advise insulin pump to? Ideally, everyone with type 1 diabetes above the age of 6. Ideally, every woman with GDM who needs insulin. But we know that cost is an issue. So if you have someone with type 1 diabetes who is not responding well to conventional subcutaneous therapy, who has lots of hypo and hyperglycemia, somebody with so-called brittle diabetes or pancreatic diabetes, and also GDM that is difficult to control, or a high-risk GDM pregnancy, very high-risk GDM pregnancy, then we would advise insulin pump. Now, pumps are also of different types, and you have something called sensor-augmented pump therapy, where the pump and the CGM, that is continuous glucose monitoring, are able to speak with each other. So it becomes a kind of a closed loop. But do remember that even the best of technologies is only as good as the person who is using it, and as good as the person who is educating the person who is using it. So, glucose monitoring, diabetes education training, continuous support is required. Continuous support. Only then will CGM and the insulin pump give us good results. So that was about one kind of delivery device, insulin pumps, which are available in our country. Now, we have routine insulin pens. We spoke of durable and disposable, but now newer generation smart pens are coming up. A smart pen is a reusable injector pen which has a smartphone app attached to it. And the moment you dial 20 units and inject it, the pen gets to know. The pen can be connected through the cloud to other people, other stakeholders. So let us say we have an elderly lady who is living alone. Uh, she injects 20 units at night. Her physician gets to know she is injected. Her son or daughter who is living in USA also gets to know that the mother is injected. So that's the advantage of smart pen. In case the injection is missed, so the loved ones know that yes, something may be wrong. Let's find out why mommy didn't take the injection. Another advantage of this smart pen is in people who forget, who have cognitive dysfunction. So if you've forgotten now, did I take my insulin today or not? Should I take it again or not? If it were to happen, with a multivitamin or a statin tablet, it wouldn't make too much of a difference to life. But if it's an antihypertensive or glucose lowering drug, it makes a lot of difference. So therefore, to find out whether one has taken insulin or not the same day, these smart pens are helpful. The smart pens will also tell you when the cartridge gets expired. So they'll tell you it's time now to change the pen, change the cartridge. So that was about insulin delivery devices. Some things that we have like pumps and some that we will have in the future like smart pens. But along with insulin delivery, we also need to measure glucose. If you can't measure it, you can't improve it. And if you can't measure it accurately, then you can't improve it accurately or appropriately. So we need to have good glucometers which are accurate. Now there are organizations. In the USA, we have the US Food and Drug Administration. In Switzerland, we have the ISO, International Organization for Standardization. These are organizations which give us they give us a framework to assess whether a particular glucometer meets expected accuracy standards or not. ISO has updated its information, I think, in 2013, and FDA in 2014. FDA is the most stringent, and they classify glucometers into two: those for use at home, those for use in hospital. So, see what the FDA says: 95% of all values should fall within 15% in the usable blood glucose range. So the meter company will tell you, yes, my meter is valid from a value of, let's say, 30 to 300. So in this range, the variability should not be more than 15% for 95% of all samples. And it should certainly not be more than 12%, 20% for 99% of all samples. If the glucose is less than 75, then almost all values should be within a 20 milligram per deciliter plus minus range. This is for the meters in hospital use. And if the glucose is above 75%, then 75 milligram percent, then 95% values should have a coefficient of variation of less than 12%. 98% should have a coefficient of variation of less than 15%. So now these are important. And the FDA also tells us that values outside of the ISO tells us that values outside of the clinically acceptable regions are outlier, and they should not be used for therapeutic decision making. So somebody comes in with one value of 600. Do not use that for therapeutic decision making. Do it again. Cross check. Somebody comes in with a value of 28. Patient is asymptomatic. Do check again, because there will be many pre-analytic, analytic, and post-analytic issues. One such issue is interfering substances. So now our monitors can be either glucose oxidase based. An example would be the betometer, or glucose dehydrogenase based. Example would be the Roche monitors, Accucheck. In general, the glucose dehydrogenase monitors like Roche are less prone to interference with drugs. The glucose oxidase monitors, however, may get interference because of drugs like vitamin C, uric acid, sugars like galactose-xylose, even paracetamol in high dose or L-Dopa in high dose. And do not forget hypoxemia, because they are based on glucose oxidase. So if the person is hypoxemic, then the glucose value will not be right. So do spare a minute to check which meter you have, and be aware that if your patient has got high uric acid, high sugar content, or is taking high doses of paracetamol, or is in hypoxemia, your glucose oxidase monitor may not work very well. So be aware of this. These are glucometers that we speak about, but there are other continuous glucose monitoring devices. Let us learn the current method of classifying them. So we have RT-CGM, that is real-time CGM. These are systems that measure and display glucose levels continuously. You can wear them for up to around 5 days, and usually they are used in in-hospital settings. You can use them in GDM as well. We have ISCGM, intermittently scanned CGM. They measure glucose levels continuously every 15 minutes, but you have to scan them. So how do you scan them? Either you can scan them yourself as a person living with diabetes. So that is ISCGM. And you can do that on your mobile phone or through any other app. If, however, you have to go to the doctor to get your glucose value scanned to get the visualization, that is called a pro or a professional CGM. And the data may be blinded or visible to you. That depends upon the doctor, because he has the reader. So you have to go there. Now, the professional CGM is slightly more economical, but the ISCGM, if your patients can afford, it is slightly more expensive, but they can do ISCGM, and they can install a system which gives or which does not give alarms. All these will assess not only glycemic values, but also glycemic patterns and trends. So they will help us understand how glucose levels are behaving. When this when this RT-CGM gets connected with uh, a CSSI or CSII or insulin pump, then it's called an closed loop or artificial pancreas. Do remember once again that patient education is important for using technology. We have other technologies as well. Sometimes in sick patients, we may need ketone monitors, usually not needed in OPD practice. And then diabetes apps is something I would like to talk about before we go on to questions and answers. Diabetes apps are very important. You will find many apps on your phone which will tell you how to calculate calories, which will tell you how to do carbohydrate counting, which will tell you how to uh, manage your diabetes. We call this digital therapeutics. So if you can find a good company which can take care of your patients, this will help you. So the digital therapeutics company will charge, let's say, something like 5,000 rupees for 12 weeks, and they will offer dietary support. They will offer the help of an exercise physiologist and also a trained mental health professional. And what they will do is they will help your patient strengthen himself or herself, empower himself or herself. They support the doctor, they do not compete with the doctor, and you end up getting a much healthier and much happier patient. So, with this, I'd like to thank Mr. Sharma from Lucknow and Dr. Anshul Singhai from Bhilai, Chhattisgarh, and also Dr. Vinayak Sharma for logging in. Dr. Shari Khare says, I'm not able to fix my fasting glucose even after basal insulin. So, and 6 months back, I took semaglutide as well. So, let's look at the simple things, non pharmacological. The first would be sleep hygiene. Try to go to bed early. See what the quality of sleep is. Do you have obstructive sleep apnea? That would be a common cause. Do you have to get up repeatedly during the night to go to the bathroom? It may be a prostatic issue, it may be a gynecological issue. So these are common things. First is sleep hygiene. So we fix that. Sometimes, if sleep quality is an issue, then you might wish to take a drug which helps in inducing sleep. Do not take a benzodiazepine, take a non benzodiazepine. The drugs of choice would be either lemborexant, 5 milligram at night, or zolpidem, 5 milligram at night. We begin with them, just one of those. So that first was sleep hygiene. Second is food and beverages at night. So common causes: too much of alcohol at night, too much of full cream milk at night. This is the common etiology of poorly controlled fasting glucose in Haryana. So too much of alcohol, too much of full cream milk at night. That is beverages. Diet: a high carbohydrate diet or a high fat diet taken at night. So try to change the diet. So first was sleep hygiene. Second was diet and beverages. Third is exercise. If you do a vigorous exercise at night, do not do that because that will stimulate the sympathetic tone. You will not be able to sleep properly and glucose will also rise. However, if you do light exercise, that will maintain parasympathetic tone. So just light exercise at night, maybe a very slow kind of a relaxed kind of a walk after dinner. That may help in improving glucose. So far we've talked of non-pharmacological. We did during sleep hygiene talk about zolpidem and lemborexant. They are pharmacological but not glucotropic drugs. Second aspect would be pharmacology. Basal insulin is of different types. If the basal insulin is not acting, either there is hyperglycemia going on throughout the night, especially in the morning. This is called dawn phenomenon. Or there is hypoglycemia occurring at night, and then there is the rebound hyperglycemia. Hypoglycemia will occur at 3 a.m. because that is the time of maximum insulin sensitivity. So first of all, we check glucose levels at night. You might wish to do pre-dinner, 2 hours after dinner or bedtime, 3 a.m. and fasting. Once you're sure that glucose levels are not falling at night, then we can either increase the dose of basal insulin or we can change the basal insulin to ultra long acting. The drug of choice would be degludec, followed by glargine U300. We may also wish to add drugs which help in reducing fasting glucose. Some examples would be metformin, high dose at night. All the other drugs, of course, will be there. And you may wish to use imeglimin, 1000 milligram twice a day. So these are some suggestions, Dr. Khare. Another question is from Dr. Vinay Desai. That's about OSA, obstructive sleep apnea. So obstructive sleep apnea is a very common disorder. One study showed that nearly 60% of all Indians think that snoring is a sign of good sleep quality. But actually, snoring is a sign of poor sleep quality. So let's say your patient comes to you and your patient is saying, I snore a lot, or the spouse says, my spouse snores a lot. This means uh, there is a chance of obstructive sleep apnea. How do you figure out sleep apnea? Let me get the stop bang questionnaire, and I'm reading as I speak. So, stop bang, there are four symptoms and four signs that you have to look at. Stop is for snoring loudly. You snore so loudly that it seems to be louder than talking, and it is loud enough to be heard through closed doors. That was S. T is for tired. Do you feel tired, fatigued, or sleepy during the day? O. Has anyone observed you stop breathing during the sleep? And P. Do you have a history of high blood pressure, or are you being treated for high BP? So, four symptoms: loud snoring, T for tiredness, fatigue in the daytime, O for observation that you had stopped breathing while sleeping, and P is for pressure. Uh, to this stop, we had bang, BANG, and now we have four signs. So B is for BMI more than 35, A is for age more than 50, N is for neck circumference more than 40 centimeters. That means the shirt that you are wearing is more than the size is more than 40. And G is for gender, male. So bang, BMI, age, neck circumference, and G for gender. If these are positive, these numbers are positive, then you have to rule out obstructive sleep apnea. Earlier, the only way of doing a sleep study was to send the patient to hospital and get admitted. But now you can do a screening level test at home. So they have these monitors actually. So you can do a sleep study from ResMed is one company. They will apply a small monitor here on the finger. It's just this much size, like my thumbnail, like my fingernail. And you apply it at night. You connect it to a smartphone, and over 3 nights you get a sleep study, and then you know whether you have to treat that or not. So this is one uh, important topic: obstructive sleep apnea. Dr. Anshul Singhai shares a very good practice, and he says that for sleep disturbance, uh, you don't have to rush to pharmacotherapy. Along with sleep hygiene, the other things that we would suggest, he adds meditation or yoga nidra, progressive muscle relaxation technique. And that is right because this also stimulates the parasympathetic tone. So thank you, Dr. Anshul, for that wonderful suggestion. And Dr. Mr. Anand Basu also says that all the good smartwatches help you study REM and NREM. REM is rapid eye movement, NREM is non-rapid eye movement. So there are phases. NREM will have N phases: N1, N2, N3, N2. So you go to N1, N2, N3, then you come back to N2, and then you enter REM, rapid eye movement. So these kind of phases, they keep on continuing every 90 minutes throughout the night. And if the sleep quality is good, usually you will wake up fresh, you will wake up healthy, and you will wake up with a good glucose. So this is another advantage example of technology in diabetes. Technology like the smartwatches, which help you measure your sleep pattern, the sleep studies, which help you measure your sleep pattern. These are also technologies that help us in diabetes and related complications. So we've spoken today about technology. Most of us do use these technology. We've also repeated again and again that education is important. And Dr. Anshul reminds us that simple things like yoga, meditation may also help in improving the quality of diabetes care that we give our patients. The outcomes will be better. With this, I'd like to thank you all. It's been a great discussion, and I look forward to continuing our engagement, our mutual learning with each other over the coming Sundays. And I'd like to hand over back to Team FDC now.
Thank you, sir. I think, sir, today's lecture was one of the best lectures because new technological advances has been discussed because that continuously updates our viewers about what's happening in our world where we are connected with a lot of technological advancements in our day-to-day practices. With this, sir, I would like to thank you because you have already been so tired because morning you have been taking session in Prayagraj now with us. That is too much of you of helping the community all the way traveling from one city to another and taking the session 9 p.m. every Sunday. With this, we thank you and all of our viewers being with us every Sunday. And we also would like to say that the sessions which we run through last 3 weeks was absolutely, what we say, was one of the best. We can say that the feedback we got from all our doctors was so high that they have already told us that next year find out the topics just before Ramadan, and upgrade our learnings next Ramadan also. So with this, I would definitely thank Dr. Sanjay Kalra that he has really brought in new topics and made this journey so wonderful with us. With this, I thank Dr. Sanjay Kalra for giving his time, and good night and Jai Hind.
Jai Hind.